All right, so yeah, in the comments box, if you can think about what a chronic illness is, I'd like to see what people understand a chronic illness to be. I'll give you a few minutes to put in your thoughts. Be brave.
Yep, and just type in your responses, everyone, using the questions box on the right-hand side of your screen there. You might have to click on the little arrow to get it to expand so you can put in your answer. It looks like we're having people tell us congestive heart failure, diabetes, COPD, fibromyalgia, Parkinson's, something that's not curable, that people live with the treatment, MS, and that it's the opposite of acute. It's a long-term condition or a persistent disease which may impact quality of life.
These are all really, really good answers. So I guess I could stop right now, but I won't. But you're all correct. So chronic illness is basically an illness that is incurable. We'll get into some of the details about this, but what I'd like you to think about, we're going to have a quiz now, and we're going to open a poll. I'm going to give you a list of 5 conditions, and I'd like you guys to answer which ones you think are related to a chronic illness. We'll give you a few minutes to answer those.
All right, and the poll should be up on your screen now, so you can pick all of the acute illnesses that you think apply. And based on the live poll results, I'm letting you all know because I don't think you can see them. About 69% of people are saying myocardial infarction, 75% of people are saying influenza, 40-something% are saying digitally induced nasoorbital trauma, and 22% of people are saying Alzheimer's disease.
All right, so most of you have voted. So we'll go through this one by one. So this is a case of digitally induced nasoorbital trauma, which is something we picked up in medical school. Apparently this does happen once in a while when people have car accidents and they're disimpacting their noses, but we'll pass on that. So that's obviously an acute illness. A lot of you picked influenza as an acute illness, and that's correct. It's obviously an acute infection. Myocardial infarction, that's a very interesting one, and we'll get to that. But that one would not necessarily be manifested as an acute illness, and we'll explain to you guys why that is. So I'll move on to the differences between acute and chronic disease. So obviously an acute illness by definition comes on suddenly. Generally the course is brief. The resolution, like influenza, is usually complete, although some people may have permanent consequences from their acute illness. The goals of care are generally to cure the illness. The duration is, again, generally brief, and the cost to the healthcare system is usually minimal. So you get pneumonia, you get a chest x-ray, prescribed antibiotics, and within a couple of weeks to months, you're feeling better and the problem has been solved. As opposed to a chronic illness, which is by definition progressive, and there's often a latent symptom-free period followed by a sudden exacerbation. And that's where myocardial infarction is interesting. So myocardial infarction presents acutely, but it is essentially a manifestation of atherosclerosis, which is itself the chronic illness. You've got long-standing vascular risk factors, you develop hardening of the arteries, all of a sudden a ruptured plaque occurs and the disease becomes clinically manifest. So from that perspective, the myocardial infarction is best interpreted as a manifestation of a chronic illness. These illnesses are generally lifelong and generally progressive. Some conditions like tuberculosis are chronic and eventually get cured, but most chronic illnesses are going to be lifelong and progressive. They usually do not resolve, and here's a key factor. They have remissions and they have relapses. So we'll get more into that, but we often hear of congestive heart failure leading to hospitalizations or COPD exacerbations. These are manifestations of exacerbations of an underlying chronic disease. And those are things that generally make people feel worse and end up in the emergency. And that's really one of the main goals of chronic disease management, is to prevent these. Goals of care depend. So after myocardial infarction, certainly the goal may still be to prolong life, and there's different ways to manage heart disease in that sense. Maintaining quality of life is important, and as you get older, maintaining function, maybe getting even some rehab, but eventually we do talk about end-of-life care as being part of the spectrum of care goals and decision and care choices that we make for people with chronic disease. So essentially, the duration of the chronic illness is lifelong, and that's why they're so expensive to treat. So again, think about the course of a chronic illness. We all start more or less healthy. Some of us develop risk factors. Some of them are genetic. Some of them are lifestyle. Some of them are things that we can do something about. We develop what's called subclinical disease. So in Vietnam, when soldiers were killed in Vietnam and had autopsies, they were 19, 20, 21 years old, and hardening of the arteries was already evident there. Subclinically, they hadn't had symptoms from it, but the disease was there. Eventually, the disease becomes symptomatic. Eventually, symptomatic disease progresses and the illness becomes more advanced and end stage and leads to death. And all throughout the course of the illness, there are opportunities to intervene. So obviously, from a public health perspective, primary prevention, which is avoidance of the occurrence of the disease in the first place by treating and preventing exposure to risk factors, is important. Secondary prevention basically relates to subclinical disease that's been diagnosed, and we want to treat the person to prevent worsening of the disease and worsening of the symptoms and complications. Tertiary prevention relates to established disease that we want to prevent the worsening. And so people with stable angina, people with congestive heart failure, people with COPD are things that we want to treat so that they don't get worse and the person can maintain a reasonable quality of life. So the question is, where do we want to intervene? We are talking about long-term care, but I'm going to challenge you, and again, we can open up some questions. Can you think in long-term care of examples of tertiary prevention or secondary prevention or even primary prevention?
All right, and we'll give everybody a minute to think of your response to this question. And again, just type in your response in the questions box on the right-hand side of your screen.
Examples of conditions that might be related to tertiary prevention or secondary prevention. So palliative care is a good example of, can someone?
Yep, somebody said palliation. Somebody else is saying calcium and vitamin D supplementation for fracture prevention and osteoporosis.
Heart failure. Prevent hypoglycemia for diabetics. Disease-specific diets. Exercise. So those are things, examples of interventions that can be used in either primary, secondary prevention, tertiary prevention. But again, by primary prevention, we want to think of what could we prevent for the first time ever in people in long-term care. And potentially, if they have no cognitive impairment, that's something you might want to prevent. Preventing stroke, if they haven't had a stroke. Obviously, tertiary prevention includes the management of chronic diseases like heart failure, but palliative care as well, right? We're treating people who have a lot of symptoms to reduce their symptom burden. So essentially, we can think of different ways of preventing things in long-term care, not just treating diseases that pop up or only when diseases are symptomatic. So let's move on. So what do we need to consider when thinking about helping a person manage chronic disease? Well, there's certain things that we want to think about. So already a lot of people have mentioned different treatments, such as exercise or maybe some disease-specific issues or proper nutrition, right? So you think about day-to-day management, there are invariably going to be medications, but a lot of you have pointed out the importance of non-pharmacological treatments, which are very critical. We know, for example, that treatment of depression mild to moderate depression treated with exercise. Exercise is as good as antidepressants. So those are extremely important. We want to prevent complications and identify exacerbations early because we know they're going to happen, so we don't want people to get too sick on our watch and essentially try to keep them out of the hospital. Other things you want to worry about are preserving function, preserving psychosocial engagement, the economic impact, right? Not just to the health system, but to the family of your long-term care resident who has to take time off when that resident is sick. It costs money. Caregiving. So even though your spouse is in a nursing home, you are still the caregiver. And also for the informal caregivers as well as the formal caregivers in the nursing home, the personal support workers, they have relationships and attachments to these residents and they don't like to see them sick. So these are major issues. With long-term care and aging comes comorbidities, these things called geriatric syndromes like falls and cognition, which really affect our ability to manage these conditions. And the very important thing, especially in long-term care, is the person's goals of care, which I would argue, and probably most of you would agree, is the most important determinant of how you're going to proceed with planning care. So just some data. Again, we're talking about long-term care. This is from a paper by John Hurdy's a couple of years ago called The Iron Lungs of Gerontology. And they were looking at different characteristics of long-term care residents across multiple Canadian provinces. So a couple of things we note: most long-term care residents are women. Most of them are well above the age of 85 in many of our jurisdictions. Obviously, many of them have spouses still and family members. And here's some of the diseases, and you'll notice these are all chronic diseases: Alzheimer's, heart failure, COPD, diabetes, cancer. Cancers now, we think of breast cancer, people with breast cancer survive up to decades or even longer. Many cancers are now chronic diseases. Stroke is an acute manifestation, but it leads permanent consequences, so it's an important comorbidity. And with the population aging, we are seeing more and more people with chronic, serious mental health disorders in long-term care. All of these are chronic illnesses. If we think of things that matter to them in terms of potentially things we can potentially interfere on and improve, functional decline is quite important. Improving communication is a major issue. A lot of people are delirious, and obviously that affects their ability to enjoy a quality of life that's reasonable. Restraints. We're getting better, but we're still not perfect. Cardiorespiratory symptoms. We've talked about heart failure and COPD. A lot of people have trouble breathing, are feeling dizzy, have chest pain. And falls obviously are a geriatric syndrome that results when people accumulate multiple deficits and are therefore at risk of having falls. So falls in many ways is a consequence of having multiple chronic diseases. And any one of these may be a pertinent goal from the patient's perspective. And when we look at other issues, again, this is based on the MDS data from across Canada. A lot of people have very significant cognitive impairments. A lot of people are functionally impaired. There's a high burden of depressive symptoms, behavioral issues related to dementia, personal expressions that are problematic are very common. Health instability. So the CHESS scale we'll talk about measures health instability. Over half of people in long-term care are unstable from their health perspective, and that relates specifically to chronic disease management. A lot of people are in pain, and a lot of people, because of all their symptoms, are unable to successfully engage in social activities in the nursing home. So these folks are very complex. And then the question becomes, how can we organize care? So I'm going to talk about heart failure a little bit because actually the literature around heart failure in long-term care is very well developed. And it's an archetype of a chronic illness. It's sort of the best exemplar of all the things that make chronic disease management tricky. So we speak of heart failure as beginning when the person's in the community, they're independent, and they get hospitalized. And they have a decline in their function because they're sick. We have treatments, they improve, they go home. The nature of heart failure, like any chronic illness, is it will relapse. There will be ongoing relapses. And what you note is after each relapse, there is a chance of death, as shown by the little arrows, but people will survive, but they lose ground every time there's an exacerbation. As they have more advanced disease, they have more frequent exacerbations, they start needing rehab, home care services. Sometimes we have new treatments that can, pull the rabbit out of the hat temporarily and maybe move back the clock, but you're still on this kind of trajectory. Eventually, they get so sick that they need a nursing home, or they end up in hospice palliative care, and you enter the terminal phase, which is hard to predict. It can last 6 months, it can last 18 months, it's hard to tell. Lots of complexity, right? As they get older, they become more medically complex. They develop mental health problems, cognition, mood, anxiety. They become more and more frail. The burden on the resident, on the person gets higher, the caregiver gets stressed, and the healthcare system sees that burden as well. Outcomes change. That's complicated, You have your first episode of heart failure, your goals might be, I want to live as long as possible. As you get more complications and become more frail, the goals change from longevity to quality of life. Keep me out of hospital. I'd like to get to my daughter's wedding in 6 months, and eventually palliative care. There are therapies throughout all of these stages. There are pills like we talked about, exercise, nutrition. They have to be optimized, in the case of heart failure, throughout almost all of the course of the disease. Right? And we have to engage the system, the patients, there's caregivers informally, and the long-term care team, because the nature of the beast is there will be a decompensation. So we want to be able to monitor for symptoms and catch these things early so we can intervene and reestablish balance and keep them well and out of hospital. Care goals shift, and here the importance of advanced care planning is quite critical. So Wagner developed this thing called the Chronic Disease Prevention and Management Model, which many of you have heard of, which essentially was developed for primary care purposes. And really, the literature in terms of chronic disease management and long-term care is fairly new. So we're talking about multidisciplinary care. The goal is to optimize care and prevent acute care utilization, and obviously, I would suggest to meet the person's goals. Self-care is critical, and so in the community, it makes sense, the literature would say, to try to train the person to understand their disease, understand their treatment, so they can participate in their care as much as possible. And arguably, this is still critical well into long-term care institutionalization. Heart failure is an interesting one again, where some people want to have salt and vinegar chips. And really, at the end of life, you may want to allow that to happen. So you have to have that negotiation with the patient. They need to understand that chips cause salt retention, cause worsening heart failure. So if they're educated, they may choose to forego the chips, or they might be insistent that they have chips, in which case we give them extra diuretics. So managing these things means engaging the person so that their voice can be heard and we can come to some mutually agreed upon way to manage their problems. Care integration and coordination. Even in long-term care, there are specialists in the community, there are ER visits. Care has to be integrated, and we have to make sure that information follows the resident. System has to be redesigned to improve access to community-based resources. So again, in long-term care, one looks at the proportion of geriatricians who spend a large portion of their practice in long-term care. It's slightly above 0%. Cardiologists, respirologists, other specialists really spend little time in long-term care. So how do we provide access to specialized services if they need that? Clinical information systems. And again, I won't go into that because you're all keenly aware that information flow between long-term care and other sectors is still poor despite electronic medical records. And then we have to make sure that evidence-based or best practices guidelines are known to the providers regardless of where the person is. And that's an ongoing challenge because of the fast change in evidence that there is out there for these chronic illnesses. That said, as complicated as that may seem, we know that it works for diabetics. They have better control, fewer foot ulcers, fewer amputations. We know that this works for people who have COPD. We know that this works for people with heart failure, at least in the community. So how do we do this in long-term care? There is an Ontario chronic disease prevention management framework, and this is from their website, and this is the diagram. And unfortunately, the diagram tells you what the ingredients are, but they don't tell you how to mix the ingredients, and there's no recipe here. And it's a bit of a confusing diagram. So, prepared and proactive system, no argument there. Patients have to be involved. So in the framework, there's a patient here and the patient is there as well. So that doesn't really help us in terms of how do we organize care for the person. And the question about who does what to whom is not answered by this because we have basically lots of blobs that say that we have to have nurses and nurse practitioners and PSWs and pharmacists and on and on and on involved in the care, but that framework doesn't tell us how these people work together to meet the needs of that patient. So I would suggest that we need to get back to the basics and look at how a chronic disc condition should be approached from a clinical perspective, and that can help us conceptualize how we might change or adapt our care processes in long-term care to deal with these issues. So first thing first, can a resident have a chronic illness of interest? Right? Do they have osteoporosis? Do they have COPD? Is this heart failure? What do they have? Sometimes the chart is useful, sometimes the chart is not useful. So are there risk factors that might suggest that we want to spend a bit more time looking for this disease in this person? Do they have a hunched posture that would suggest that they've got undiagnosed osteoporosis? Did they have bypass surgery in 1991? And is that why they can't breathe right now? They've got chronic heart disease that's turning into heart failure. The other thing is we need to assess risk. So some people may present in a way that's sicker than others. Clearly, if we want to manage the diseases properly, we want to assess the sick people sooner than later. So we look for risk factors for condition, and we look at the urgency with which we might want to address this person's needs. We'll go through these boxes in greater detail soon. An assessment has to be made, and in long-term care, it should ideally be an interprofessional assessment. We have a variety of staff roles, PSWs, RPNs, nurses, kinesiologists, therapists, physicians, the family, and the resident. And we each have our own perspectives, snapshots on this person's day-to-day experience. All of these snapshots, when put together, will help inform a more accurate picture of whether this person may or may not have a specific disease. More history is needed, targeted physical assessment, potentially some diagnostic testing, and if things aren't clear, potentially a specialist review. But the purpose there is the best way to arrive at a more accurate diagnosis is to engage the team. If the disease is confirmed, do we need to do anything about it now? If a person is found to have osteoporosis, do they have a painful vertebral fracture that needs to be addressed today because it's causing major symptoms? If this person is found to have COPD, do they need intervention today to improve their breathing? If they have heart failure, do they need to be given diuretics today? It's important also, when talking about acute management, to refer back to this person's advanced care plan. We deal with the acute issues, then here's the tough part, and here's the challenging part. And we'll spend more time talking about these boxes later. but it's the chronic management. We've identified the disease, we've stabilized the resident, now what? What are the person's goals? Let's review the advanced care plan again. How do we engage the long-term care team to keep an eye on that resident? How do we assign tasks and responsibilities and establish communication protocols so that if the person is experiencing a decompensation, how do we identify this early, deal with it early, and keep the patient as stable as possible? Are there any treatments that we may want to optimize? We'll talk about that a little bit later. For some diseases, it might mean more medications. For other diseases, it might mean less. And yes, let's engage the resident and the family. They need to know about this illness. They need to understand what we're doing and what the treatments are for so that they can buy in and they can be active participants in their care. Eventually, the resident will destabilize. That's inevitable with many of these chronic illnesses. And then it's time for a reassessment. Again, if they're unstable, can we deal with things and restore an element of stability? But if it's difficult to stabilize, is that because it's an end-stage problem? Should a specialist be brought in? Should we review the care plan again? Hopefully things can be stabilized, deal with the acute issues, and go back to more of a chronic phase of the disease management. Eventually, though, we will reach a point where that heart failure exacerbation that we're seeing today is an indication that this person has reached the end stage of their illness, and end-of-life care processes become more appropriate. And that might involve ceasing other drugs or changing the advanced care plan or whatnot, whatever is relevant to the person's goals. So this diagram lays out the different steps that are potentially amenable to any chronic illness. So let's go through these things in a little bit more detail. So again, could the resident have a chronic illness of interest? Many ways to do it. Sometimes the chart is not helpful because you didn't get the chart. You don't have any old notes or they're not accessible. Are there suspicious symptoms? And there are ways to identify certain things. Is the person breathing with difficulty? Does the person have difficulty at night? That could relate to heart failure. Are they agitated when they sit in a chair? And this could be related to a vertebral fracture or something painful in their pelvis. Do they have risk factors? And that requires a bit of education, but not too much. Do they have a history of heart disease? Could that indicate heart failure? Have they had previous fractures? That would suggest that there is osteoporosis. Do we need to act sooner than later? And again, clinical judgment is really important. If the person is unwell, then we probably want to act more quickly. If not, then we have a bit more time to figure things out. Do we need specialized input? Sometimes the diagnosis is not clear, or sometimes the management seems tricky. Again, do we need specialized input? The point here is that a lot of these things, a lot of this information is already there, and we can and we should be proactive. We shouldn't wait for someone to be blue in the face or to have severe pain or agitation for us to actually start intervening with these chronic illnesses. By definition, the chronic illness is already there, and it behooves us to make sure that we look for them. How about risk stratification? So the CHESS scale is free. Most of us across Canada have access to the MDS. People come in on admission from hospital or from home care. They've had a IHC done. There's this thing called the CHESS scale, which really relates to health instability. It goes from 0, which is stable, to 5, which is highly unstable. And it includes items related to recent declines in ADL, cognition, presence of established advanced disease like heart failure, COPD, or kidney failure, and something's up. They're not drinking enough, they've got edema, they've got shortness of breath, they're vomiting, they've lost weight, they're not eating. CHESS works quite well. So this is data from a recent study across Canada of people in nursing homes with a variety of neurological diagnoses. And this is their survival after the assessment from 0 days to 180 days, so basically 6 months. And you can see the drop off in survival from chests of 0 to chests of 5. And essentially, the higher the chest score, the higher the mortality. And the important bit is here, right? If they come into the nursing home with a chest of 3 or more, within 10 days, they've got at least a 10% mortality rate. So that's a clue that if the chest is high, this is someone who probably needs a bit of a closer attention sooner than later. So that's a useful instrument. I use it myself quite often to determine who I need to see first. Why is targeting important? Again, a very brief example from heart failure management in the community. We know heart failure clinics work, but these folks conducted a clinical trial where they actually stratified patients by degree of frailty. And I'll just show you their frailty score here. So advanced age, presence of cognitive impairment, mobility problems, urinary incontinence, or difficulties with activities of daily living. The more of these they had, the more frail they were. And what it shows is that the event rates for frail people in this management program were lower. The frail people benefited the most from the intervention, and then those who were not frail. And in fact, for those who were not frail, the intervention cost more money. For those who were frail, the intervention saved money. So that's the idea of risk stratification, is if you identify someone's at high risk, you need to spend a bit more time on them and spend some more resources because the payoff is going to be greater. So now that we've done risk stratification, we need to formalize the assessment. We talked about the importance of the team. I would include anyone in that team. I worked in a nursing home where the custodial staff are part and parcel of the assessment. And they see these folks every day. They know when something's wrong. So whoever you've got, listen to them. The resident is critical. They will tell you there's something up. Sometimes they won't have specific symptoms to report, but they know something's wrong. PSW engagement. PSWs provide 80% of the nursing care, and I think most people will accept that if they're not engaged as part of the care team, that's a bit of a failure of the system. These folks are there. They see the residents. They know what's going on. They can be given some education to help articulate what they see and communicate effectively to the team for more additional assessment. It implies the reliance on clinical skills. And one of the things I want to do is take my med students to nursing homes because then they don't have chest x-rays to work with and to fall back on to feel safe. Nursing homes rely on clinical skills and observation, and it's important to make sure that any educational needs related to that are addressed. The role of the specialist is increasingly important. There's now evidence from the realms of psychiatry and heart failure, even in long-term care, that bringing specialists into nursing homes to work with the teams in a shared care approach does improve the accuracy of the assessment and also builds capacity amongst the team for the team itself to become better at the assessment. The bottom line is you can't manage something that you're not sure exists or you haven't confirmed. So diagnosis is really important. Acute management, we talked about that. Again, make sure the chronic disease that you've identified doesn't need any specific acute treatments, extra diuretics, or steroids for the breathing. Always important to review care goals. A lot of people's minds will change every time they've had an exacerbation, so it's important to review the care goals. The chronic management is, again, where the action should be. Monitoring is critical, and you cannot monitor appropriately if you have not engaged the entire team. And again, I speak especially about PSWs, about custodial staff, about members of your nursing home team who see the residents on a regular basis. Engaging them, telling them what to look for, encourage them to speak to registered staff, and keeping them involved in the plan, letting them know what you're doing. You know, for example, we've given Mrs. Smith some extra diuretics. Please keep an eye on her breathing. Is very important. Medications, engagement of the pharmacist and the physician, sometimes less is more. In diabetes, we know that relaxing glycemic targets is actually associated with better outcomes. So less diabetes monitoring and backing off on the meds is probably a good thing. Heart failure, it's the opposite. More medications related to heart failure may be better for the person. So medications, we talk about deprescribing, and yes, a lot of people get drugs that they don't need, but we really should be talking about appropriate prescribing. I can't say enough about anticipation. Right? A chronic illness is inherently unstable, period. Never assume that the person is going to be stable indefinitely. The risk fluctuates over time. Exacerbations develop on their own schedule, not by appointment. So if the physician happens to be there once a week and the heart failure exacerbation occurs in between those two visits, there's got to be a way to deal with it on that day. So your team needs to be aware and proactive and observant and must communicate effectively. Developing a management plan. So it's easy to speak of clinical practice guidelines, but I think someone figured out that it would take more than 48 hours a day to treat a patient with multiple chronic illnesses according to guidelines, meaning it's impossible. So you have to have a way to balance the guidelines with the patient's care goals, make sure that this is anchored in long-term care and is organized in long-term care to keep things organized and as opposed to disorganized, where physicians or specialists prescribe different drugs that are at odds with one another, and the locus of decision-making is lost from the nursing home. So the American Geriatric Society has this framework. You know, what is the person's primary concern? What are their goals? If their goal is to stay out of hospital, that's the important thing. If their goal is to attend the wedding in the summer for their daughter, that's the important thing. If you can relate any chronic disease management suggestions to their goals, you'll be more successful. It's important to have a better complete review of all the issues that the person faces. And again, I would encourage people to use the MDS more fully. Many physicians are not aware of its contents. Many people think it's an administrative tool. It's very useful stuff. It gives you an overview of the person's needs, and it's important to use it in your clinical care planning. Okay? So all these are good things, my little green smiley faces. The American Geriatric Society says focus on a specific aspect of care. I don't know. It's in long-term care, and I've never seen one disease stand out more than other conditions. So I would take exception to that. Obviously, you need to understand what all these current medical interventions are, and is the person comfortable with the plan? If they are, then perhaps you need to leave well enough alone. We have had a resident where we work who has had chronic psychiatric issues, and every time we try to fiddle with her meds, she gets worse. So really, that's a very important lesson. If things are fine, don't mess with them. Consider patient preferences. Is there reliable evidence? So there's an education piece here that's important. Let's consider prognosis, and we'll talk a little bit more about that, because sometimes treatments that have their benefits in 5 to 10 years are no longer relevant in a nursing home. That's where it's important to get your pharmacists on board and your physicians. You know, what are the interactions? Are some drugs causing the diseases to get worse? Are some drugs interacting with one another? You give a diuretic to someone who's on a cholinesterase inhibitor, the Aricept might be making their bladder twitchy. And then you start giving them diuretics, they become quite incontinent and very unhappy with you. And so these are very important interactions to think about. What are the harms? What are the benefits? And that's where you have that conversation with the person. Remember that frailty does not mean do not treat. Some frail persons are more likely to benefit from certain treatments than others. And again, heart failure, COPD are very good examples. If we can prevent a COPD or heart failure exacerbation, we prevent ADL decline, which is more likely to benefit a frail person. And again, think of when the intervention is going to have an impact. Again, we don't want to give treatments that will not have a beneficial impact within the person's life expectancy. Reassessment is critical, right? It's a chronic disease, persons change, and it's important to review the treatments on a regular basis, including reviewing the advanced care plans. So let's talk about this, right? The life expectancy. We now know that tight glycemic control, which is meant to prevent long-term complications in the community, really don't apply to someone who's got 18 to 24 months left to live. They've already got their long-term complications. So what are we trying to achieve with diabetic control? We want to prevent hyperglycemia or hypoglycemia. And perhaps tight blood sugar control is no longer important. Heart failure, as a comorbidity, mortality is 50% at a year. So some other treatments, some other therapies that require a longer time horizon are no longer relevant. And again, your chest scale is a useful marker of prognosis in terms of trying to make decisions about whether certain treatments are helpful or not. Finally, how do you do this? Everyone wants more money from the Ministry of Health, and no one gets it because there's not that much more money to go around. So think about what care quality comes from. So this is a framework developed by a colleague of mine at Lakehead University that we've used for heart failure, but again, it applies to any chronic illness. The most important determinants of quality care are actually how your team gets along. The interprofessional relationships, the trust, the communication, and the respect. If you have a well-functioning interprofessional team, you are more likely to succeed in providing quality, patient-centered practice. On top of that are your resources, and we'll get into a bit more of that. But if there are educational resources available, that's helpful. Administrative support for chronic disease management is critical. How do we know we're improving? That's the administrative's job, to tell the team how things are going in terms of quality care improvement. Professional systems, educational systems, and the environment within which your long-term care home is situated are critical as well. I mean, we always talk about providing education after the fact in nursing homes or primary care, where really we should be thinking, why aren't people coming out of med school or nursing school with these skills? But again, the most important determinants are whether your team is able to provide best practices in an interprofessional way. And so some experience that we've had from heart failure, we've done some work in heart failure using funding from the Heart and Stroke Foundation to see how could we integrate heart failure management in nursing homes. Again, heart failure is interesting, but it's an archetype chronic illness. It sort of hits all of the high points of what a chronic illness is. And so we did a broad-based consultation in nursing homes to figure out how we could apply the principles of heart failure management to the long-term care setting. And there are gaps. Obviously, there are health system issues, right? Limited access to diagnostics and specialists, and poor communication between long-term care and other sectors like home care or hospitals. But the big ones are the communication gaps within the home, particularly amongst the different staff roles, and knowledge gaps about heart failure, about chronic disease management, about the main chronic diseases. So how do we address these? And when do we address these? Right? So heart failure is a tricky thing to do, but where do things fall apart? It's important to understand where things fall apart for the residents so we can design care processes that help avert crises. So long-term care episodes where communication was particularly relevant, new resident admissions, when the physician visits and rounds, shift change, poor communication there means we lose opportunities. Monitoring weights for heart failure residents, right? If we monitor their weights on a regular basis, perhaps not daily, but often enough, we will know when they get sicker from fluid retention. And how do we interrupt our routines that are often imposed from outside by regulations to deal with a resident who's all of a sudden noted to be acutely unwell. So we designed an intervention that we've tested, that we keep pilot testing, but basically it includes broad-based education for nurses and PSWs, with these staff developing their own communication strategies for these key heart failure episodes, bringing in the physicians to understand the function of the team and how to work with the team in terms of addressing that barrier related to trust, and then doing bedside rounds and case discussions with an embedded specialist. And our pilot work so far shows that your staff members are more knowledgeable about not just the disease, but aging in general and communication amongst themselves. They are more aware of early signs and symptoms of chronic disease. They are more at ease discussing things with each other. There is less fear of the physicians. I know physicians sometimes don't realize this, but the teams were scared of the docs. And the physicians, in turn, once they understood that the importance of engaging with their team, are actually becoming more integrated members of the care team. Still early days, more work to be done, but seems to work. We've just completed a scoping review of the literature, and again, heart failure has the most evidence in terms of this area of care, is that we can develop interventions to improve knowledge and communication. One of the benefits, which is interesting, is job satisfaction goes up. And whether this has an input on staff turnover, we don't know yet, but that's an interesting finding. We can prescribe drugs to a higher degree, and we can reduce acute care utilization and costs. So chronic disease management seems to work. Missing ingredients, or the essential ingredients. The education of the nurses and the PSWs has to be multimodal, but one of the key things is bedside teaching, going to see residents together and assessing them together, and that's where the critical learning happens. Bringing in external consultants. So there seems to be a very clear signal in the literature that, again, bringing that specialist nurse in, or pharmacist, or physician, as long as they are part of the care team, seems to be beneficial as well in terms of successfully managing chronic disease. Ongoing barriers, the physicians are hard to engage, and there's probably we can spend a lot of time discussing that. Administrative support, this has to be wanted by the administration, and it has to be embedded into policy, and that requires a robust quality assurance framework so that people know when you're improving. And if you don't improve, you have to have mechanisms to understand where things aren't working well and adjusting course. And finally, we're talking about a zero-sum game. We can't think about managing chronic diseases by adding additional documentation burden, because that's not going to work. There's only 24 hours in a day, and people are busy. So optimizing the use of your resources, using the MDS, working with the care teams that you've got, building capacity. And let's face it, some diseases need more emphasis. Other diseases like diabetes maybe require less emphasis, less blood sugar checks, less insulin doses, and that's okay too. So you can't just manage one chronic illness. It has to be more of a comprehensive approach to chronic disease management at the nursing home level. So I'll point out the importance of quality assurance and of education are fundamental in planning interventions for chronic disease management. So just to summarize, it's important to remember that chronic illnesses get worse over time, and many of them have exacerbations that are not predictable. And it shouldn't be a surprise that they're going to happen. It requires the team to keep an eye on things. The goals of care are critical, and essentially we need to think about softening the inevitable landing. This person is going to die, most often from that chronic illness or the sum of chronic illnesses. But we need to think about optimizing treatment so that this landing becomes softer. Deprescribing, I think, is a problematic concept to some degree, because some treatments should be intensified where others should be reduced. Mobilizing your teams and engaging your docs is critical, but not always easy. And quality assurance needs to be routine. So we need to measure outcomes, not just the MDS ones, but others. We need to have a mechanism to feed back to the entire team and a mechanism to figure out how we change our approach. And just to finish up on culture change, I think it's important to make sure the physicians get engaged in this to a greater degree. So sorry, I went a bit longer than I wanted to, but we'll just opening up to questions now.
All right, thanks very much, George. And everyone, if you have any questions for Dr. Heckman, please type them into your questions box on the right-hand side of your screen there, and we'll answer them over the next few minutes.
Can't see the questions. Yes, the slides will be made available. So higher blood pressure. So blood pressure is interesting. So there's been a couple of studies recently that claim to have looked at frailty. One was the HIVET study that said, let the blood pressure target go high to around 150. And then SPRINT said, no, the blood pressure target needs to be lower. So be aware that not all frailty tools are created equal, and that's the problem here. So the people in the older study, the HIVET, which says let the blood pressure target be 150, these people actually had weight loss and they had a very low BMI, so they were probably more frail than the SPRINT patients who had a very high BMI. And so I think the issue with blood pressure, it's worth treating because it prevents heart failure and stroke. And again, if that's consistent with a person's goals, that's important, and those are major comorbidities. But you titrate, for a frail person, 140 to 150 is quite reasonable, as long as they don't have symptoms when they stand up. And I think that's the tough part, is to try to make sure that when you start getting signs of hypoperfusion in the brain, are they dehydrated? Should you switch from a diuretic to another drug? Calcium channel blockers can cause dizziness when people stand up. But you want to use that approach using orthostatic vitals and symptoms to individualize targets. And again, for frail people in long-term care, I think the HIVET trial is more applicable. And in the HIVET, the target blood pressure was 140 to 150. So a couple of questions. One is related to decisions about ED transfers. I think there's a couple of things here. You want your advanced care plans to be solid. And by that, it means not just, do you want to go to hospital or not? You have to understand the person's chronic illness. So if you have a good chronic disease management approach and you identify exacerbations early, odds are you'll be able to manage them in the home. And so that's an important point. The decision to transfer to the ED often is when someone is noted to be really sick at a very inconvenient time and you're kind of stuck. The other thing is being able to contextualize the person's life expectancy using more robust information. So if someone has very poor cognition or a high chest score and they have markers of advanced heart failure and they develop heart failure, I think it's important to be able to speak to the family and say, this is the natural progression of the disease. What are the care goals? And we can keep you comfortable. I think reassurance about being kept comfortable often allays the fears. Being more certain when you speak about, overall person's health status is helpful to reassure the family that, their loved one is going to be kept comfortable, that you can apply treatments in the home, and that an ED visit is not necessary. Sometimes you can't win that one and they will want to have an ED visit, and it may go well, it may go poorly. When they come back, it's time to reopen the conversation. How did that go, right? And so I think the best tool is to be prepared ahead of time with good advanced care discussions that are grounded in perhaps more details about the different chronic illnesses that person may have, looking at their overall level of function and frailty, and realizing that some treatments can be, and reassuring that some treatments can be provided effectively in the nursing home. As for the MDS, I think one of the things is to gently push back. So I've seen many physicians, I remember one person was referred to me to rule out depression, and the physician had ordered a Cornell scale, and I was able to get to see that person within 5 weeks, which I thought was good. But clearly, if they'd looked at this person's depression rating scale from the MDS, it was off the charts. And when you went to talk to that person, she basically wanted to die. And I think rather than saying to the physician, sure, we'll do the extra tool, I think is to work with the nursing staff and with support from the director of care to say, no, we won't do a Cornell. The depression rating scale is high. Do you know what that means? And then providing that education. I think there's other ways to do it. We're happy to provide webinars about the MDS. I use it in my practice all the time. One of the issues has been that it was rolled out across Ontario as more of an administrative tool, so people don't view it as a tool for providing clinical support. But once they realize this, that it's valid and it's useful, then it becomes more evident to the physicians that it's a useful thing to do. And the other neat thing that happens is the nurses and the docs start talking in the same MDS lingo. So that does promote interprofessional communication.
All right, we have one more question there about communication.
So that's critical. And you're asking a question to which there is not a good answer. Part of the issues is the nursing homes and the hospitals use different assessment instruments. I had a student do an inventory of assessment instruments in Waterloo, Wellington, and there were, 7 or 8 dementia tools used across the region and a dozen or so ADL tools. So the fact is that when information is sent from the nursing home to the hospital, they don't know what it means and vice versa. There's ways to standardize this information, and that does require political will. The other thing is make sure that we pick up the phone. And I would even invite local hospitals and nursing home staff to get together, because we are so fragmented as a system that we have no idea of what the other goes through on a regular basis. So I think solving that is not going to be a trivial task, but I think it does require greater engagement between the two sectors and more standardized assessment. There's a very long question here about, I'm going right up to it. Thank you for the overview. From Rosa. I think you're right. One of the things I would suggest, and perhaps, is to speak to Schlegel Villages, which is part of an international effort called the Seniors Quality Leap Initiative. And the Seniors Quality Leap Initiative was founded in the United States, but includes nursing homes from across Canada and the US. And they get together as a collaborative to essentially share solutions for these things. It's based around the use of the MDS quality indicators. And as a group, they will each choose 1 or 2 quality indicators to focus on in the upcoming year or two. And they compare each other's performance. Those who do well share their solutions. Those who have trouble also are given access to these solutions. Trying to utilize the information that we have at our fingertips is critical. Trying to engage the residents is critical. But I think taking a step back and looking at the sum of all the care processes that are in place in the nursing home is going to be very important. Again, I remember maybe 10 years ago going to some nursing homes where every person with diabetes was marked off and they had their blood sugars done on a regular basis, and there were all sorts of sliding scales. And then I met a colleague who's an endocrinologist who said 90% of that is unnecessary. So that time burden that's related to managing that diabetes, plus the cost of all the glucose strips, if you can look at that and implement a program where you manage diabetes in a more rational, evidence-based way, will give you time and will save money. And so that it's an incremental thing, addressing the heart failure up front and using the instruments that are available can help start the discussion up front so that the family and the residents have a better idea of what to expect in terms of their health, so that you've got the conversation ready to go when that exacerbation does happen. And so there's no easy solution, and this is extremely complicated, but I think there are resources available. And again, I'd invite you guys to contact Schlegel Villages about the Seniors Quality Leap Initiative. That's an international thing, because that's how we eventually are going to start sharing best practices and improving things across the board.
All right, that looks like all the questions we have, and thanks again everyone for participating in this webinar. We would love to know your feedback on it and any ideas you have for future webinars. So a short online survey link is being emailed to you soon, and that will include a PDF of the presentation slides and a link to the recording within the next few days. And thanks again to Dr. George Heckman for sharing with us this detailed and very practical information. And special thanks to Holly Hebner from the RIA for her wonderful webinar support. We're ending the webinar now, but feel free to get in touch with me anytime with your questions, and I can pass them on to Dr. Heckman for you. Enjoy the rest of your day, everyone.